Hey folks, Scott Weingart here, and this is an EMCrit podcast. Today on the podcast, we're going to discuss pulmonary embolism. A couple weeks ago, I published that malpractice case. A lot of questions came up from it. Can we use the PERC score in patients with COVID? Can we use the PERC score in patients with pleuritic chest pain? And where do we stand in 2025 on things like simultaneous administration of anticoagulation and fibroanalytics? I had all these questions. Well, who could I possibly go to for the optimal answers? Well, that should be obvious. Jeff Kline is the name for pulmonary embolism research in emergency medicine. He's been on the show before, but it's been at least a decade, so it was high time to get him back. And we went through all of it. So you're going to get the answer to all the questions that came up and so much more. Before we dive in, really quick, for 2 years now, I've been working on a course with my partner in crime, Peter Johns. And if you don't know Peter's name, then you haven't been listening to the podcast. Peter is, I think, the best vertigo educator out there in emergency medicine. And he just has been putting out phenomenal educational resources. But everything's in kind of disparate locations. It's on YouTube channels. And I wanted a course on dizziness and vertigo for emergency medicine, critical care, neurology, physical therapy, anyone dealing with patients who have vertigo complaints. Because I feel I'm pretty good at it. I think better than most. I've read all the available literature and I've talked to so many people for the podcast, and yet still I was confused exactly what to do in certain circumstances. And I know from teaching in academic medical centers that certainly the residents and many of my co-attendings really find this an area that they are not happy with. They do not want to pick up charts from dizzy patients. They do not want to see it. They hope the other team has to deal with these patients who come in with dizziness complaints. And there's no reason for a major swath of neurological presentations to be ones that we hate dealing with. So I figured we could fix this. And the way to fix it is with a course. And so for 2 years, Peter and I have worked on this course. And I think it's pretty phenomenal. I have learned a ton. And each time I go through the course, editing and reviewing, I'm like, oh crap, I can't believe I still learned something new. By the end of this course, you will be better than 98% of the people out there on dizziness and vertigo. You will no longer fear it. You will have an absolute comprehensive understanding of how to proceed with each type of dizziness and vertigo that presents. You'll understand how to screen for posterior stroke. You'll understand all of the different types of BPPV. There's not just one. That might be an eye-opener right there for you, as there's actually 3 types. You'll be able to diagnose vestibular migraine. You'll be able to do the Hintz exam and the Epley maneuver and the Dix-Hallpike and all the others, supine roll test, all of the tests you need to know. You've seen the words, you've taken board exams on them, and yet you have no idea how to do them properly, because I know I didn't. So if that all sounds intriguing, and I hope it does, then go to vertigocourse.com. That address again is vertigocourse, all one word, .com. If you go to vertigocourse.com, you will see all of the stuff I've just spoken about. You'll understand what you're going to get. 16 hours of CME, multiple different learning modules. It's all video-based, and there's a sample unit there as well, so you could actually see for free one of the units and get an idea. So if all this sounds like something you want, just go to vertigocourse.com, and I think you'll love it. All right, let's get into the show. So the first thing I wanted to talk about, Jeff, is we had a malpractice case we published on the podcast that was pretty horrible. An ED doc saw a young kid. They had recently been diagnosed with COVID. They had some pleuritic chest pain, and the patient was low risk by the risk stratification scores. They perked out. They had none of the 8 criteria. And then they wound up 11 days later having a massive pulmonary embolism and dying. Now, there were 2 things about the case that I wanted to talk to you about. One of them was his presentation was with pleuritic chest pain. And I know you had written a letter to the editor that a lot of the patients who were PERC negative and turned out to have a P had pleuritic chest pain. What is your feeling on the interaction of pleuritic chest pain and the PERC score?
The biological basis is most pleuritic chest pain comes from something like a pulmonary infarction. That's usually the inflammatory nidus of the pleuritic pain. And those wedged in clots are likely to have low D dimers and oftentimes normal vital signs.
Based on what you're saying, if a patient does present with pleuritic chest pain, can we use PERC?
Yes, you certainly can. I try to do the best I can to say if you're going to have a false negative, it is probably more likely to happen in a patient with pleuritic chest pain. Most of those people do fine.
When you were feeding PERC all the variables to see which ones actually had importance, I got to imagine pleuritic chest pain was in the mix and fell out as one of the criteria. Is that right?
Correct.
So,
Correct.
okay, so that we have an answer there. If it's just pleuritic chest pain, that should not invalidate the use of PERC.
For the last 30 years, I've been teaching that the most important type of pleuritic chest pain that should worry you is the patient takes their finger and points at it. It's a relatively unusual thing that people with pleuritic chest pain will take their finger and point where it hurts. If they do that, I'm pretty much failing them on PERC right there. So this is just based medicine, not evidence-based. It's just me saying I've seen this so many times and often in M&Ms. So when the patient's pointing with the finger, stop and think.
All right, let's just really lock in that piece. This is future Weingart, of course. So pleuritic chest pain is not something that invalidates the PERC. You could still use PERC in pleuritic chest pain. But if the patient indicates an area on their chest with their finger saying, it just hurts right here every time I take a deep breath, Jeff's opinion is that is enough to invalidate the PERC score. What about EKG findings? We could talk about this one in particular in a second, but what about EKG findings in general? They're not part of PERC. They could have been. So what's your feeling on that?
Yeah, let me come out of the box and say this, that I've been very active in medical malpractice, probably done 150 cases that alleged failure to diagnose pulmonary embolism. Almost all of them are a dead person. And if I do both sides, I try to do more defense than plaintiff. But if I get a defense case, I'll get 800 pages. They're all now in PDF and they're on a computer. I don't get hard copies anymore. But the first thing I'm flipping to find is the EKG. Because if I find the EKG that has what I call the Daniel criteria, which includes the T-wave inversion in V3 through V4, and of course S1, Q3, T3, tachycardia, incomplete to complete right bundle blank spot, and ST elevation and AVR, these are all the findings I'm going to be looking for. And if I get a red hot EKG, there's no way for me to defend it. I can't. I would be impeached from prior testimony. And this is one of the most important things I point out in any lecture is the computer will not read it. Every now and then, if you see some of the older programs in Marquette, it will say, consider pulmonary embolism, but the algorithm is looking for goofy stuff like a big P wave, which is not part of pulmonary hypertension, and it will look for the S1, Q3, T3, but it doesn't look for those other findings of acute pulmonary hypertension that I just named. And I believe that an emergency physician has to recognize.
All right, that's a strong statement. So you've heard it right from the proverbial horse's mouth. You need to know these EKG findings. And as a result, I've already scheduled a EMCrit Wii with Pendle, the cyborg that is, I think, one of the world experts on EKG findings in various emergency situations. And we're going to hear from him about which ones you need to know and the fact that AI will probably obviate your need to know this if you're using it. So that will be coming in the next few weeks. Look forward to that. Until then, for the patients you're seeing until that occurs, go and look up the Daniel criteria and see the ones that you need to be looking for on every EKG for a patient with chest pain or shortness of breath. That being said then, Jeff, knowing that the uptake of information is dismal, but the uptake of rules actually gets out there, is it not worth putting out a revised PERC that has a 9th criteria saying EKG screened for the absence of, and then listing the ones you said?
I love the idea. As a pure scientist, it's going to require a validation of thousands of people, and maybe it could be done retrospectively enough just to add it in. But what I think it does is it fails you way up top. You don't get to the 15%. You could even put it way up there at the top. ECG, no pulmonary hypertension findings, you can still go to the Gestalt low. But I love it. I think if we had the machine reading acute pulmonary hypertension, I'm going to make a number up out of the blue, but that we would save 100 young lives in the United States each year, 100 people.
All right. So then that's a pretty definitive answer there. The last piece on PERC, I think everyone knows it's never been validated in pregnancy, but postpartum, I'm not sure how many people know. So would you say PERC's acceptable in postpartum at all? And then how far postpartum could you start using PERC again?
Post-vaginal delivery, yes, but my own gestalt is going to be fairly high pretest prob, especially if there's a C-section. Then we got a 30-day lockout by PERC.
Hmm.
But after vaginal birth, there are a lot of nuances to that. Is it the first child that the patient has had? If it's the second or third, they're a lot lower risk because if they were going to clot, they were probably going to clot on the first birth. There are some nuances there, but it can be used after vaginal birth.
Okay, that's super helpful. Anything else you want to mention on PERC before we go on, Jeff?
I do, and I want to give a teaser that we finished our NIH-funded PERC PEDS study, 4,030 children with suspected PE in the emergency department. Everyone said, Kline, there's no way you're going to get your suspected 4.5% prevalence of PE in children. No way. They were right. It was 6.5%. And these are not subsegmental PEs. These look the same in terms of their size and distribution as in adults, median age 15 years. PERC PEDS validated extremely well with 99% sensitivity, but 20% specificity. So I'm excited to have a decision rule to guide the ability to exclude PE, but also to give you a cognitive construct of how to begin to think about who in the world do I need to start worrying about in PE when it comes to a 15-year-old. I think PERC PEDS gives us some construct to think about that.
I can't wait for that. It makes me think now there's an additional 2 questions I want to ask. One is, do you think that prevalence you've got was because of COVID?
No. COVID actually reduced, if they were COVID positive, it reduced the probability. And that's where we, in our CDC work, where a surveillance network I had called REST Blends, which ran from 23 until end of 24, it actually reduced the probability of the outcome of pulmonary embolism. So it serves as an alternative diagnosis. Whether or not Hunan was even a risk factor in ambulatory patients could be argued. But like that Med-Mal case is arguing, it was COVID, so it was high risk. I disagree with that and can show you the data that is not the fact in 2025.
So that's fascinating. So in New York, we saw a type of COVID that was never seen in the rest of the country, that first wave. After that, I think our COVID was exactly the same. But that first wave, we were having like 40-year-olds dead an hour after arrival on a regular basis without any comorbidities. We were seeing clots everywhere. And then COVID became a very different disease a year later. Do you think all of the idea that the clotting was happening was based on first wave that then just petered out, and that's why it wasn't seen later on?
Oh, absolutely. And the same, everything worse happens in West Detroit, and everyone clotted in Sinai Grace ED, but not so much in some of the more private hospitals in Detroit. There was even subsets of it, I think, within regions or cities.
So what I'm extrapolating is you can use PERC in COVID patients.
Yes.
Okay.
Yes.
Anything else on PERC before we move on to age-adjusted D-dimer?
No, just to reemphasize that PERC is relevant once something crosses your mind that I'm thinking about pulmonary embolism. Not everybody over age 50 needs a D-dimer, or maybe you and I are both PERC positive. I don't know.
Yeah, I hit that a year ago. Yep, absolutely.
Okay. Yeah, so you and I don't need D-dimers. It always requires some gestalt pretest probability. So
so you're saying a relatively healthy 55-year-old doesn't automatically need testing just because by the strict PERC criteria, they don't PERC out. You could say, even though the patient is 55, I still feel that they are so low test probability that they don't need further testing.
Yeah, the words we need to remember: unexplained dyspnea. Those are the worrisome combination, even more than pleuritic chest pain. Unexplained dyspnea in a 55-year-old, we definitely need to begin thinking of.
Hey, folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So Go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Maybe this skips perk and goes straight to a D-dimer.
Gotcha. All right. Age-adjusted D-dimer. The evidence has just kept mounting, and yet I'd see most of emergency medicine not doing it. Why is that, and what is your feelings on it?
It's just the inertia of adoption.
Yep.
The different D-dimer assays and the different thresholds where you have the IL test, it will be a cutoff of 235 at one hospital, 243 at another hospital. And so I think these little nuances of the cutoffs and whether they're using D-dimer units or FEUs, fibrinogen equivalent units, it adds enough complexity to our already complex jobs that people they don't want to get into the weeds with it. I wish our laboratories would just publish it, would just put it on the result, and that would really help the doctors.
That would be amazing. All right, so it's just really an adoption issue. It's ready for prime time is what you're saying.
Absolutely.
All right. Let's move on to thrombolytics. Jeff, when we talked, it had to be over a decade ago. You were recommending at that point the simultaneous administration of enoxaparin and fibrinolytics, or if you weren't sure and you were sending the patient to CT, just give them the low molecular weight heparin, and then you could still thrombolyse them when they got out with a big PE on it. Are you still thinking that? Are you still thinking simultaneous, or what's your current thoughts?
Well, let me preempt that with large bore mechanical thrombectomy and talk about catheter directed.
We'll get there for sure
at some point. But with, in a setting where I can't get catheters, yes, my statement is still TNK is now taken over for stroke. So we don't even have alteplase in our Pyxis anymore. It's TNK. I think the safest thing for a patient at this point is 25 milligrams of tenecteplase and low molecular weight heparin injected subcutaneously.
If you already knew they were a pulmonary embolism, like you're making these decisions, they've already got him back from CT, and you're considering lysis, would you hold off at that point on anticoagulation and just give the thrombolytics, let them drift down on their PTT till they need it?
We have an absence of evidence to answer your question. If you go and look at the protocols of even Pytho, which was relatively patent, it was published in the New England Journal, they demanded a supplement that went through the anticoagulation, that it was still at the discretion of the doctors. So whether they stopped anticoagulation for some period of time or never gave it or withheld it is not clear from, every single patient. Most people like to withhold anticoagulation because when you do try to do unfractionated heparin with any type of a fibrinolytic, you always end up overshooting the PTT and the patient's bleeding, and you really just blame the combination of the two things for all the oozing that you're seeing. I never saw that with low molecular weight heparin. I see it all the time with unfractionated heparin. So a lot of people just give the lytic, wait an hour, and then start unfractionated heparin.
You know what? Let's go to catheter-directed therapy, and then maybe we swing back to thrombolytics, because I think the CDT stuff will inform a lot of the thrombolytic talk. So where do we stand in your practice on who should get catheter-directed therapies and which ones to choose?
It's so impressive to watch how much better the patients get with the thrombectomy, and they get the clot out of them, that it's almost the RCT of parachutes thing where we are. Let me remind the audience, we have 4 randomized trials involving catheters. One by Kuchar and Canary, both use catheter-directed thrombolytics. Most recently, we have one called Peerless that compared large bore mechanical thrombectomy with catheter-directed therapy. And then there's High Pytho that compared a bunch of different catheters to anticoagulation. They're all pretty much showing the same thing, that somewhere between 24 and 72 hours, if you get a catheter compared with anticoagulation only, your right ventricle looks a lot happier. The problem is 3 months later, they don't look any different. So this is a Mikey likes it thing. The cardiologists like doing it. Everybody loves the pictures that get texted around of all the clot that came out, and the patient feels better. And the one thing that I think matters is it keeps them out of the ICU, and they don't have to have a sheath in like you have to have with the catheter-directed thrombolysis. So the large bore mechanical thrombectomy is is really just, it has taken over. And the biggest ethical problem I have with it is at least 60% of humans in the United States who get pulmonary embolism will never have access to an individual who can use this device. So there's still the role for lytics in many settings, including the hospitals where I work in inner city Detroit, not just rural settings.
Yeah, absolutely. I sign on to all of that. I've been unimpressed with the idea of catheter-directed lysis in general. And I say that not in comparison to anticoagulation. I think giving thrombolytics to these patients could be immensely helpful in the right risk stratification. But I don't see any difference between catheter-directed lysis and low-dose continuous thrombolysis through an IV catheter. And so tell me where I'm wrong on that, Jeff. First of all, I've seen nothing showing me the ultrasound augmentation helps these at all.
So let me take the easy answer first, is I got to give it to, I think it was Boston Scientific who bought ECOS, that they did the trial comparing ultrasound versus no ultrasound. And actually the ultrasound group did a little worse.
Yes, exactly.
So ultrasound is done. Just throw the ECOS catheter away. I'm sorry, I'm obviously not on any payroll here. Yep. So the ECOS was a farce from the start, and it's been shown a couple of times to not add anything. Now, the question that you asked in addition is, if you bury a bland catheter into a clot and infuse say 12 to 24 milligrams of alteplase, is that any different than infusing 12 to 24 milligrams of alteplase in the antecubital vein? And a lot of people are interested in that, but we just don't have the evidence. All we have is inference.
We published on that. Not great evidence. It was an observational trial, but we had actually massive PE, not even submassive, and 25 milligrams over 6 hours. All of them completely resolved their vasopressor necessity and all their other markers, troponin, right heart strain, et cetera, all resolved in those patients. I just don't, it doesn't even theoretically make sense to me that there'd be some magic to putting the catheter right up next to it. It's all circulating continuously. So on the catheter-directed therapies, the Inari, and I don't know, maybe you differ on this, but I think we actually have to name names, because just like the large vessel occlusion, just putting in the broad category of clot retrieval, in that case, in LVO for stroke, it wasn't until they had the right generation of devices that were actually good that we really saw the amazing benefits. So we have data on the Inari FlowTriever. I don't take money, you don't take money from these people. If it was you, and I'm not wishing this on you by any means, with a sick submassive category, so you're not on vasopressors, but you're either hypoxemic or you are severely tachycardic with a shock index greater than 1, all of those markers that we're scared of, what would you take in 2025, Jeff?
I'd want the aspiration catheter.
Yeah.
And if I was narrowing my pulse pressure and getting more tachycardic, I would ask them to try to use a 6 millimeter catheter. I still feel very funny about jamming a catheter across the pulmonary valve that is 1 millimeter smaller in diameter than the pulmonary valve is. But in those patients, if you watch them on the table, they're hiccuping, they're getting VT on the screen. Nobody's looking at their blood pressure, so we don't know exactly what happens, but I'm sure it drops when that catheter crosses. But oddly, you don't see a whole lot of people having arrest when that catheter goes through. You're right about one thing that is very clear. With development of new technologies, the catheters are getting better. And one of them now is it's basically digitized. So you don't have to pull this stopcock back or pull this syringe back and then flip a stopcock. That's almost seems very rudimentary, but now it's becoming much more automated to have to reduce the number of passes and this associated pulmonary artery injury. So they're able to do more with a lower bore catheter and get the same amount of clot out. So the technology is there's a lot of money in it. So people are putting money into developing these catheters and augmenting them with computer assistance.
I love that. So let's do rapid fire then on this exact type of question, because you've answered if it was available and you had a 6 submassive, you'd want that. Let's say you were at a hospital, they didn't have that. They either had catheter-directed lysis or fibrinolytics or nothing in a 6 submassive category. What would you offer your patient in that case?
Yeah, and it always ends up taking a lot longer to get the patient to the cath lab than I want. systemic lytics, that's guideline concordant. And for the more severe PE, remember there's 14 systematic reviews and meta-analyses on the exact same topic published since Pytho. And the one thing they all agree on, and you can look this up if anybody wants to challenge me on it, is they all agree for the sicker patients, lytics saves lives. And that is a systematic review. Now, there's a lot of issues with this because it goes back to streptokinase and the crazy Herhez-Sanchez study of 8 patients, 4 of whom died without lytics and 4 did. It's a lot of cats and dogs that go into these systematic reviews, but they were all consistent that you can save lives and the bleeding risk is way exaggerated.
Yeah, absolutely. So now with alteplase disappearing from many ED formularies, do you do reduced dose TNK?
Yeah, for one reason, it comes in a 25 milligram vial. And if you use another 25 to save a life, it's worth doing. But we're talking about going from $12,000 to $24,000 just in acquisition cost. And then the patient gets charged $80,000 for 2 25 milligram vials of tenecteplase. So try to think what's $40,000 for a life. But I do think about if I can get them open with 25 milligrams, which you usually can in the patient you're describing, go for 25.
All right, great. Okay, so now I break massive up into 2 groups because I don't think massive is a good, real single shot at understanding what's going on with your patient. So for me, you have massive players that they're on a low dose of norepi, but they're stable and you have some time to decide. And then there's a second category of the ones that they're peri-code. They haven't coded yet, but so let's talk about that first category. They're on 4 mics of norepi. They clearly are sick. They have evidence of a large clot burden. Would you also choose a mechanical thrombectomy in those patients if you had that on offer?
I would definitely activate.
Yep.
And it's very context dependent. If you have a cardiologist in-house and they're ready to go, that's what I would want for me and my patient. If I was the patient, that's what I would want for me. If it was my mom, that's what I would want for my mom. But then it's a lot different if Dr. Cath Jock is in the cath lab and he's got a really complex case and he's going to be an hour, then I'm going to lyse him.
Yep. Gotcha. That brings up an interesting question, which is, what is your feeling on PERT teams for your personal practice? Where have you had circumstances where you've called them and then they force decisions that you wouldn't have made knowing the things you know on your own?
I can say that does happen. And one of the reasons that I might call and want a catheter thrombectomy, but the cardiologist is in the cath lab and can't do it. And we just end up lysing. So it's not really that someone wanted to make a decision that I thought was dumb. It's just the system wouldn't allow it. The one where I get most disappointed is the cardiothoracic surgeons want to be involved and they want to do their Trendelenburg operation and they can put the patient on pump. There's a lot of advantages. And I love these videos of these giant sea monsters coming out intraoperatively, and they're even more fun to watch than the large bore thrombectomy. I love seeing that, but every time I call my thoracic surgery colleagues on a clot in transit or whatever, it seems like they find a reason to not take the patient to the OR. Oh, too hypotensive, not hypotensive enough. You end up with this catch-22. That's probably the one place I get disappointed in PERT teams is in the planning. They're like, we need to be having more Trendelenburg operations, and then they won't take them.
Yeah, it's a GI bleed situation. But that being said, I would not at this stage of the game in 2025 want an open thrombectomy for pretty much any I can't think of one that would make me say that's the right choice for such a grievous operation.
Clot in transit.
So you don't feel lysis is the way to go on those?
The real bottom line answer that I think is reasonable and prudent is don't just do anticoagulation for clot in transit. Your idea of giving lytics is perfectly acceptable. And we can look at the work published by David Jimenez, who looked at a pretty large, like 150 individuals that had clot in transit and basically found that, and of course, there's confounding and internal bias to these studies. But if you just get anticoagulation, your mortality is about 40%. And if you get some type of reperfusion, the mortality drops to around 10%.
Yeah, no, I think that's completely the right take home. Jeff, I don't want to take up too much of your time. What should we be talking about in 2025 that we haven't hit yet?
We talked about COVID and that it's not a risk factor anymore. We talked about the fact that the large bore catheters are not really showing a long-term benefit, but are showing a short-term benefit, and people are using that to make decisions. And I can't really say it's right or wrong. We have a couple more randomized trials. One's called PE-TRACK. That's the biggest one funded by the NIH that was funded by the PI on it is Aki Sista out of Cornell. And looking forward, it's just about closed its enrollment. So that will be a really important study we'll be talking about in 2026, because if it shows no difference or equipoise with anticoagulation, that pretty much is going to say the reason to do these catheters is because you like it. It's not because you have evidence to do it. So that will be something to talk about. It's still age-adjusted D-dimer. You can use the years criteria in pregnancy. I believe that's going to get guideline endorsement. Needs to be repeated, but it is probably the best thing that we could do in pregnancy at this point to double the D-dimer threshold.
All right. Well, I can't thank you enough, Jeff. This has been fantastic, elucidated, and just a wonderful conversation.
Thanks.